Okay, so, most people with Sjogrens have never heard this part, and honestly, most doctors don't bring it up either. You know Sjogrens as dry eyes, dry mouth. That's the textbook version. But here's what almost nobody tells you. Sjogrens isn't a dryness disease. It's a nervous system disease that also happens to dry you out. And once you see it that way, a whole list of symptoms you've probably been living with, and maybe never connected to your diagnosis, suddenly makes sense. If you've had Sjogrens for a while, you've probably been told the dry eyes and dry mouth are basically the whole picture. That's the old version. The real picture is bigger. Sjogrens can reach into your nerves, your spinal cord, even your brain. Same disease, completely different story than the one you were handed at diagnosis. If you've ever felt like dry eyes and dry mouth wasn't the whole story of what you carry, type more in the comments. You're allowed to want the fuller picture of your own body. Start small. Tingling, numbness, a burning feeling in your hands or feet, or your skin misreading hot and cold. That's peripheral neuropathy, and it's often the first sign the nervous system is involved, not just getting older or sitting wrong, which is what a lot of patients get told before anyone connects the dots. Let's actually sit inside that one for a second, because peripheral neuropathy gets used as this catch-all term, and it's really not one thing. There are different flavors, and which flavor you have changes what it means and what we do about it. Hit subscribe and leave a like. That helps this channel reach more people who need it. The goal at Health Inside is 200,000 subscribers, and every single person who joins moves us closer. And if you want the full Sjogren's symptom map guide with visuals, symptom breakdowns, and additional resources, type symptom map in the comments, and I'll send you the link to access it. The first flavor is sensory. This is the tingling, the numbness, the burning, the pins and needles. Some patients describe it as their feet feeling like they're wrapped in cotton. Some describe a burning sensation at night that's bad enough to wake them up. Some notice their hands or feet misread temperature. A lukewarm shower suddenly feels scalding, or they can't tell if the floor is cold. If you've had any of that and just chalked it up to bad circulation or an old injury, that's worth a second look. Inside sensory neuropathy, there's actually a split that most patients never hear about: large fiber versus small fiber. Large fiber neuropathy tends to affect vibration sense and your sense of where your limbs are in space. That's the type that can mess with your balance. Small fiber neuropathy is more about pain, burning, and temperature perception, and here's the part that surprises people. Small fiber neuropathy often doesn't show up on a standard nerve conduction study. It needs a different kind of testing, sometimes a skin biopsy that looks at nerve fiber density. So if you've had a normal EMG in the past and someone told you your nerves are fine, that only rules out large fiber damage. It doesn't rule out small fiber involvement. That's a distinction that changes the whole conversation with your neurologist. Then there's motor neuropathy, and this one tends to sneak up slower. It's not pain, it's weakness. Trouble buttoning a shirt. Dropping things more than you used to. Your grip feeling weaker on one side. Struggling with stairs in a way you didn't a year ago. It can be subtle enough that you and the people around you write it off as clumsiness or fatigue, until it's not subtle anymore, until there's visible muscle wasting in the hands or feet, or your gait actually changes. Balance problems and falls tend to show up here too, because if the nerves feeding your leg muscles aren't firing cleanly, your body doesn't get accurate feedback about where the ground is. Here's the tool that actually separates all of this: an EMG, which stands for electromyography, paired with something called a nerve conduction study. A neurologist does this in office. Electrodes go on the skin, small pulses go through the nerve, and the machine measures how fast and how strong the signal travels. It sounds intimidating, but for most patients it's a mildly uncomfortable hour, not a big procedure. What it tells us is invaluable. Is this large fiber or small fiber? Is this sensory or motor? Is this one nerve or several? And how severe is the damage right now? That's the difference between let's watch this and let's start treatment today. If that tingling, numbness, or burning sounds like something you've been quietly living with, type tingling in the comments. You're not imagining it, and you're not alone in feeling it. Now here's the part one really want you to sit with: the autonomic nervous system. This is the part of your body running completely in the background, and you've never had to think about it, because it just works, until it doesn't. Your autonomic nervous system controls your heart rate, your blood pressure, your digestion, your bladder, your temperature regulation, even things like pupil response and sexual function. It's split into two arms, sympathetic and parasympathetic, and together they're constantly making thousands of tiny adjustments so your body runs itself without you noticing. When Sjogren's involves this system, the disruptions show up in places nobody thinks to connect back to a rheumatologic disease. One of the patterns here is called dysautonomia, and a specific version of it is POTS, postural orthostatic tachycardia syndrome. If you stand up and your heart rate shoots up, you feel dizzy, lightheaded, sometimes like you might pass out, and this happens consistently. That's not just low blood pressure or being out of shape. That can be your autonomic nervous system failing to regulate blood flow properly when you change position, and in a patient with Sjogren's, that's worth raising with both your rheumatologist and either a neurologist or a cardiologist who specializes in autonomic disorders. Alongside that, a lot of patients with dysautonomia describe being unusually intolerant of heat or cold. Not I don't love the heat, but genuinely feeling unwell, dizzy, or wiped out by temperature swings that don't seem to bother anyone else in the room. The gut gets pulled into this too, because your digestive system runs almost entirely on autonomic signaling. Difficulty swallowing can show up. Something called gastroparesis can develop, which is delayed stomach emptying. Food sits longer than it should, and patients describe feeling full almost immediately, nausea after eating, bloating that doesn't make sense given how little they ate. Diarrhea, constipation, or swinging between the two. Bladder symptoms, trouble fully emptying, or urgency that doesn't match how much fluid you've had. And for some men and women, changes in libido, which again traces back to autonomic nerve signaling, not to anything psychological. None of these are separate problems, each needing their own explanation. They can be one thread, running through one disease. If your heart's ever raced for no reason, or the heat wipes you out more than it should, type dizzy in the comments. Your body isn't being dramatic. It's asking to be heard. Now I want to walk you through the case that changed how seriously I take all of this, because it's the moment where nervous system involvement in Sjogren stops being an inconvenience and becomes something that needs emergency attention. It's called mononeuritis multiplex, and it shows up as sudden, dramatic loss of function in a specific nerve, most often described as a wrist drop or a foot drop. Not gradual weakness building over months. Sudden. One day the hand or foot just doesn't lift the way it should. What's happening underneath is that a major nerve supplying that limb has become so inflamed that it stops conducting signal properly. I've had patients come through the emergency room with this, get admitted, and then get a rheumatology consult because nobody else could explain what was going on. At the time I saw them, they genuinely could not extend their wrist, or their ankle. That's not a metaphor. The hand or foot was just hanging there, non-functional, until we got steroids and immunosuppressive treatment on board to bring the inflammation down and give the nerve a chance to recover. If reading that scared you a little, take a breath. This is rare, and most people with Sjogren's never go through it. Type strong in the comments as a reminder that your body has been fighting for you this whole time, even on the hard days. That's the peripheral story, nerves in the arms, legs, hands, feet. But Sjogren's can climb higher than that, into the central nervous system itself, the brain and spinal cord, and this is where things get genuinely serious. The warning signs at this level look different from tingling in your feet. Confusion that doesn't fit the moment. A stiff neck. Headaches that are more severe or different in character than anything you've had before. Dizziness that's new and doesn't resolve. Weakness that's more global than my hand feels weak, more like one whole side of the body. Vision changes that come on acutely. I've personally seen a patient come into the hospital in a coma, and Sjogren's affecting the brain was the underlying cause once everything else got worked up. One of the diagnoses we watch for here is encephalitis, severe inflammation of the brain tissue itself. It can cause seizures, confusion, and in serious cases, coma. Treating it means strong steroids and strong immunosuppressive therapy, fast, because brain inflammation is not something you sit on and monitor. Getting to that diagnosis usually means a lumbar puncture, testing the spinal fluid, alongside an MRI of the brain, and sometimes a CT scan as well. And here's a piece that matters clinically. Before we can call it autoimmune encephalitis from Sjogren's, we have to rule out infection causing the same picture, because bacterial or viral causes of brain inflammation need a completely different, and completely urgent, treatment path. That workup takes real coordination between rheumatology, neurology, and infectious disease. Related to that is meningitis, inflammation of the meninges, which is the protective covering around your brain and spinal cord. Most people hear meningitis and think exclusively of a bacterial infection, and that's a fair association, because bacterial meningitis is a true emergency. But autoimmune disease, including Sjogren's, can cause meningitis on its own, without any infection involved. It shows up with headache, a stiff neck, fever, and sensitivity to light, and just like the encephalitis picture, it's treated with steroids and immunosuppressive medication once infection has been ruled out. Then there's transverse myelitis, inflammation of the spinal cord itself, and out of everything on this list, this is one of the ones I take most seriously when I see it. I've had patients with transverse myelitis from Sjogren's who develop paralysis in part of the body, depending on exactly where along the spinal cord the inflammation hit. Loss of bowel or bladder control can happen too, because those functions route through the spinal cord. Some patients lose the ability to walk, at least temporarily. I've watched patients recover meaningful function with aggressive treatment, which is genuinely encouraging. But the fact that a disease people associate with just dry eyes can produce a picture like this is exactly why the nervous system side of Sjogren's deserves so much more attention than it gets. And finally, stroke risk itself can be elevated in some patients with Sjogren's, tied to the broader inflammatory and vascular processes the disease can drive. That's one more reason cardiovascular and neurological risk factors deserve ongoing attention in Sjogren's care, not just symptom management for dryness. If that section felt heavy, that's okay, it's meant to inform you, not frighten you. Type scene in the comments if you just need a reminder that what you're carrying is real, and it matters. I want to be really clear about something, because I don't want this to just sit with you as a list of frightening things. The vast majority of nervous system involvement in Sjogren's lives on the milder end. Tingling, some numbness, maybe a bit of temperature sensitivity, heat intolerance. That's uncomfortable, it's worth mentioning to your doctor, but it's not an emergency. The severe end, the comas, the paralysis, the sudden wrist and foot drops, is far less common, and it's exactly why it gets missed. Doctors are trained to think of it as rare, so it doesn't make it onto the radar even when the early warning signs are sitting right there in a patient's chart. That's the entire reason I ask every single Sjogren's patient in my clinic head-to-toe questions about their nervous system, every visit, even when it's not what they came in for. Not because I expect to find something catastrophic every time. Because the earlier we catch peripheral neuropathy, the earlier we catch signs of autonomic involvement, the more likely we are to intervene before it escalates towards something like mononeuritis multiplex or CNS involvement. Early recognition is the entire game here. So here's what I actually want you to do with this. If you have Sjogren's and you've been living with tingling, numbness, unexplained heart racing when you stand up, stomach symptoms nobody's connected to anything, or new weakness anywhere in your body, bring it up specifically as a nervous system question, not just I've been feeling off. Ask directly, could this be neurological involvement from my Sjogren's? That question alone can change the direction of a visit, because it tells your doctor exactly where to look instead of leaving it buried in a list of vague complaints. And if you or someone you know is dealing with anything closer to the severe end of this list, sudden weakness in a hand or foot, confusion that's new, a stiff neck with fever, loss of bladder or bowel control, sudden vision changes, that's not a wait for the next routine appointment situation. That's an emergency room conversation, today. If you needed to hear that most of this stays mild and manageable, type hope in the comments. Catching things early is the whole point, and just watching this is a step in that direction. Let me tell you why this gets missed so often, because it's not doctors being careless. It's how medical training actually works. When you're in medical school, Sjogren's gets taught inside a very specific box. Dry eyes, dry mouth, positive antibodies, maybe some joint pain. That's the version that shows up on exams, so that's the version that sticks. The nervous system chapter of Sjogren's tends to get one line, maybe a paragraph, buried in a textbook most students skim once and never open again. I went through the same training. I remember dry eyes and dry mouth clearly. I do not remember the nervous system section clearly, and I had to go back and relearn a lot of this once I started seeing it walk into my clinic. So think about what that means downstream. Your primary care doctor did the same training I did. If you go in describing tingling in your feet, and you already carry a Sjogren's diagnosis, dryness is the box that's going to light up in their head first, not nerves. If you describe your heart racing when you stand, that's more likely to get filed under anxiety or deconditioning than autonomic dysfunction from a rheumatologic disease. Nobody's failing you on purpose. The framework most doctors were handed just doesn't include this chapter in a way that's memorable enough to act on. That's exactly why I built a habit in my own clinic of asking head-to-toe questions every visit, regardless of what a patient came in for. I'll ask about tingling, about weakness, about heart racing, about heat tolerance, about bladder symptoms, about swallowing, not because I expect a scary answer every time, but because if I don't ask, most patients won't think to bring it up. They don't know it's supposed to be connected. Why would they? Nobody told them. If you've ever felt dismissed or unheard by a doctor, type valid in the comments. What you were feeling was real, even when no one connected the dots for you. Now let's talk about what actually happens once nervous system involvement is caught, because I don't want to leave you with a list of scary symptoms and nothing about what comes next. The first step is almost always figuring out exactly which part of the nervous system is involved and how severely, because that changes everything about the plan. 4 peripheral symptoms: the tingling, the numbness, the weakness. That usually means a referral to neurology for that EMG and nerve conduction study I mentioned earlier, sometimes alongside blood work to rule out other causes of neuropathy, because diabetes, vitamin deficiencies, and thyroid problems can all cause similar sensations, and we want to make sure we are treating the right cause. If small fiber neuropathy is suspected and the EMG comes back normal, a skin biopsy looking at nerve fiber density can confirm it when the standard test can't. For autonomic symptoms, especially anything suggestive of POTS, there's often a tilt table test involved. You lie flat, then get tilted upright while your heart rate and blood pressure are monitored continuously, which captures exactly what's happening to your circulation when you change position. That test alone can be the difference between "it's probably just stress" and a clear diagnosis with a clear plan. Once we know what we are dealing with, treatment generally falls into 2 categories working together. The first is disease control, actually calming down the underlying autoimmune activity that's driving the nerve inflammation in the first place. That's where steroids and immunosuppressive medications come in, and the specific choice and dose depends heavily on how severe the presentation is. Mild peripheral neuropathy might be managed conservatively and monitored. Something like mononeuritis multiplex, or CNS involvement like encephalitis or transverse myelitis, needs aggressive treatment started quickly, because nerve tissue that goes without blood flow and without inflammation control for too long doesn't always recover fully even after the inflammation resolves. Time matters here in a way it doesn't for the dry eye and dry mouth side of this disease. The second category is symptom management, running alongside disease control rather than instead of it. That's things like specific medications for neuropathic pain and burning sensations, physical therapy to help with weakness, balance, and coordination, medications and lifestyle strategies for autonomic symptoms like POTS, things like increased fluid and salt intake under medical guidance, compression garments, gradual position changes, and targeted treatment for GI symptoms like gastroparesis, which might mean dietary changes, medications that help the stomach empty more efficiently, or working with a GI specialist directly. If you're in the middle of trying to get answers right now, type progress in the comments. Every appointment, every test, is one step closer to a plan that actually helps you. I want to walk you through one more case, because I think it captures why I care so much about getting ahead of this instead of waiting for it to show up as an emergency. I had a patient, already diagnosed with Sjogrens for a few years, who'd been describing tingling in her feet at her regular visits for months. It kept getting noted, kept getting mentioned, but never really investigated further, because it wasn't dramatic and she wasn't in acute distress. By the time she came to me, she'd also developed some mild hand weakness she chalked up to a repetitive desk job. When we finally ran the EMG, it showed a mixed sensorimotor neuropathy that had clearly been building for a while. We started treatment at that point, and she did well, but I think about how much earlier we could have caught this if tingling in the feet had been treated as a nervous system red flag from the very first time she mentioned it, instead of something that got quietly logged for months. That's the pattern I want you walking away with. Nervous system involvement in Sjogrens isn't usually a single dramatic moment. It's often a slow accumulation of small signals that individually seem minor and easy to dismiss, and only in hindsight look like an obvious pattern. Tingling here. A little weakness there. A racing heart that gets blamed on caffeine. Stomach symptoms that get blamed on stress. Each one on its own sounds forgettable. Together, in someone who already has Sjogrens, they can be the nervous system quietly raising its hand. So if you're living with this disease, here's the practical version of everything we just covered. Keep a simple running list of anything that fits this pattern: tingling, numbness, weakness, balance changes, heart racing on standing, heat or cold intolerance, swallowing difficulty, GI symptoms that don't respond to usual treatment, bladder changes, or anything neurological that feels new. Bring that list to your rheumatologist specifically, and ask the direct question, could any of this be nervous system involvement from my Sjogrens? That question does more work than describing the symptoms alone, because it tells your doctor exactly which chapter to open. And if anything ever escalates fast, sudden weakness in a hand or foot, new confusion, a stiff neck with fever, sudden vision loss, loss of bladder or bowel control, or anything that feels like it's moving quickly rather than slowly, that's not something to schedule around. That's an emergency room visit, the same day. If you're planning to bring this list to your next appointment, type ready in the comments. Advocating for yourself like that is one of the strongest things you can do. There's another layer to this that I think gets overlooked even more than the physical symptoms, and it's worth naming directly. The misdiagnosis path a lot of patients go through before anyone lands on, this is your Sjogrens affecting your nervous system. I've had patients tell me they were worked up for multiple sclerosis because of neurological symptoms and imaging findings that can genuinely look similar. I've had patients told their fatigue and brain fog were purely psychiatric, or that their GI symptoms were irritable bowel syndrome with no deeper cause investigated, or that their racing heart on standing was an anxiety disorder. None of those explanations are unreasonable on their own. They are common conditions, and doctors are trained to reach for common explanations first. But when someone already carries a Sjogren's diagnosis, and a cluster of neurological symptoms shows up, that existing diagnosis should move up the list of explanations being considered, not stay parked in the probably unrelated category while other workups happen first. This is actually one of the more useful things you can do for yourself as a patient. When you're describing a new symptom to any doctor, don't just describe the symptom in isolation. Say the sentence, I have Sjogren's, and I'm wondering if this could be connected to that. That one sentence does something powerful. It moves the conversation from what's the most common cause of this symptom in the general population, to what's the most common cause of this symptom in someone with a known autoimmune disease that's documented to affect the nervous system. Those are two very different diagnostic starting points, and you're the only person in the room who can make sure the second one gets considered. If you've ever been told it was just anxiety or just stress, and you knew there was more to it, type heard in the comments. You knew your own body. Trust that. I also want to spend a minute on the emotional side of all this, because I don't think it gets talked about enough. Living with a chronic disease that's already invisible in a lot of ways, nobody can see dry eyes and dry mouth from across a room, and then discovering it might also be doing things to your nerves, your heart rate, your digestion, that's a lot to carry. A lot of my patients describe a specific kind of relief once they learn their tingling, or their racing heart, or their stomach issues have an actual explanation and aren't just them being anxious or falling apart for no reason. There's something genuinely stabilizing about hearing, this is a known part of the disease you have, here's what we are going to do about it, instead of being told repeatedly that nothing seems to explain what you're feeling. If you've been living in that uncertain space, I want you to hear this clearly. The symptoms are real, they have a mechanism, and there are things that can be done. If living with this has felt isolating at times, type together in the comments. You are not carrying this alone, even on the days it feels that way. I'll also say this, because I think it matters for how you approach your own care going forward. Not every patient with Sjogren's develops significant nervous system involvement. A lot of people live with this disease for years and their experience really does stay centered on dryness and joint discomfort, managed well, without ever developing the more serious neurological complications we've talked about. I'm not telling you all of this so that every patient watching starts anxiously scanning their body for signs of encephalitis. I'm telling you this so that if these symptoms do show up, you and your doctor recognize them for what they are immediately, instead of spending months or years chasing the wrong explanation first. Let's talk for a second about what a good follow-up conversation with your rheumatologist actually looks like once nervous system involvement is on the table, because knowing the right questions to ask changes how useful that appointment is. Worth asking. Has my antibody profile or any of my blood work suggested a higher risk for nervous system involvement? Worth asking. Given what I'm describing, does this sound more like peripheral nerve involvement, autonomic involvement, or something we should be checking centrally? Worth asking. Should I be referred to neurology now, or is this something we monitor first? Worth asking. If we do start treatment, what does the timeline look like for expecting improvement, and what does it mean if things aren't improving on that timeline? Those specific questions tend to get much more concrete, useful answers than a general, "Is this normal?" because they signal to your doctor that you understand this isn't just an unrelated inconvenience, it's a recognized part of the disease you're already managing. If you're saving these questions for your next visit, type "prepared" in the comments. Walking in with the right questions is how you take your care back into your own hands. One more thing before I bring this all the way home. If you're a caregiver, a partner, a family member of someone with Sjogren's, this matters for you too, because you're often the person who notices the subtle stuff first. You might notice they're dropping things more than they used to before they've noticed it themselves. You might notice they get unusually dizzy standing up from the couch. You might notice they're skipping meals because their stomach's been off in a way that doesn't resolve. Those observations are genuinely valuable, and gently naming them, "Hey, I've noticed you seem to get dizzy a lot when you stand up, have you mentioned that to your rheumatologist?" can be the nudge that gets a symptom investigated months earlier than it otherwise would have been. If you're a caregiver or partner who's been quietly paying attention to the small stuff, type "noticed" in the comments. What you do matters more than you probably realize. So here's everything, put back together into one picture. Sjogren's dries you out. That part's true, that part's well known, and it's not going anywhere as the headline symptom most people associate with this disease. But underneath that, in the same disease, in the same patient, there's a nervous system story that can range from mild tingling that's uncomfortable but manageable, all the way to sudden nerve loss, brain inflammation, and spinal cord involvement that require emergency treatment. Most patients live on the milder end of that range. Some don't, and the difference between a good outcome and a bad one, in the more serious cases, often comes down to how early it gets recognized and treated. Let me leave you with a simple way to hold all of this in your head, because I know we covered a lot of ground. Think of it in 3 tiers. Tier 1, the most common tier, peripheral nerve symptoms. Tingling, numbness, burning, temperature misreading, mild weakness, some balance changes. Uncomfortable, worth mentioning, worth an EMG if it's persistent, generally manageable once identified. Tier 2, autonomic symptoms. Heart racing on standing, heat or cold intolerance, GI symptoms like slow stomach emptying or swallowing trouble, bladder changes, shifts in libido. Easy to misattribute to anxiety or unrelated GI conditions, genuinely rooted in nerve signaling, and worth a specific conversation about autonomic testing if the pattern fits. Tier 3, the least common but most serious, mononeuritis multiplex causing sudden wrist or foot drop, and central nervous system involvement, encephalitis, meningitis, transverse myelitis, elevated stroke risk. These need fast recognition and aggressive treatment, and they're rare enough that most patients will never experience them, but common enough among Sjogren's patients as a group that every rheumatologist and neurologist should have them on the radar. If you take one thing from this video, let it be this: dry eyes and dry mouth were never the whole story, they were just the chapter that got taught the loudest. The nervous system chapter is just as real, and now that you know it exists, you're in a completely different position than you were 10 minutes ago. You can actually go looking for it instead of hoping someone else brings it up first. If you made it this far because you needed the full picture, type "stronger" in the comments. You're walking away from this more informed, and more equipped, than you were when it started. None of this means panic. It means, if you've got Sjogren's and something in this list sounds familiar, tingling, weakness, heat intolerance, a racing heart, brain fog, that's not you being dramatic, and it's not unrelated. That's your nervous system telling you something, and it's worth a real conversation with your rheumatologist, not a shrug. If this connected some dots for you, share it with someone else living with Sjogren's, because most of them are getting the dry eyes and dry mouth version too, and missing the rest of the story.